Hi, I'm Brad Power, and this is the Prostate Cancer Lab or Cancer Patient Lab. And today we're going to talk about personalized dosing. This is a subject which we've covered once before with Meena Nikanjam. She was going to be joining us, but unfortunately is ill and will not be able to join us. So we have three patients who will be talking about their experience with personalized dosing. Dr. Paul Van Camp and Jeff Krolick, and then Russ Hollier will be joining us. Get this. And I should read our disclaimers. So as usual, anything you say can and will be published. So if you don't want to be published or your comments posted or whatever, please don't say anything and disguise your name on the screen. And of course, this is just information for information purposes only, and it's not meant to be medical advice. You should take any decisions with your medical team. Let me do a quick share screen to set this up. I hope you can see my screen. It's small text, but again, for those of you who have an opportunity, I was going to read it, but it's too long to read all of it. But basically, we've got a setup here. I'll try to give a few highlights, and I think Paul will pick up on this idea as well. That dosing is typically the dosing that you get is what was the dosing that was in the original clinical trial that approved the drug. And therefore, the dosing is typically done at maximum tolerable dose. And then the way it's applied is typically maximum tolerable dose until failure. And there's a possibility that people metabolize medicines differently, and that lower doses might be equally effective and have fewer side effects. So there's a discussion about thinking about how can you personalize or dosing or reduce dosing based on an individual. And the solution is to do more testing to try and figure out how you would personalize your dosing. And you'll hear a couple of stories, as I said, from our patients who've done that. And we'll start with Paul. As you know, Paul is both a trained medical doctor as well as a prostate cancer survivor, and it's very knowledgeable and is very helpful to other patients. So, Paul, why don't you start on your views on on drug dosing, personalized dosing, and how and actually how you've applied it to yourself.
Thank you, Brad. Yes, that's a good introduction. In considering drugs for cancer in general, drugs in general, and for prostate cancer specifically, we've seen several new and useful drugs come out into practice in very recent years. And these drugs are FDA approved. And the requirement for FDA approval is that they go through stage 1, 2, and 3 clinical trials. Stage 1, they take a few patients and they do escalating doses. They keep pushing the doses and see how much they can get away with until there's an unacceptable toxicity. Then they take the level right below that, which was acceptable toxicity, and they test that in larger phase 2 trials to refine it, to decide what dosage regimen and is going to go on to stage 3, which leads to FDA approval based upon statistical analysis of the results over a period of time to an endpoint. And the endpoint usually is focused on the median patient, meaning if there's 100 patients in a trial, the 50th patient, either a progression-free survival or overall survival. So it doesn't look at the bottom 20% or the top 20%. It looks at that theoretical median patient, which is not actually a real person. It's a derivation, because for overall survival, they can't wait for the last patient to die. They wait for half the patients to die. Pretty brutal. And that's the dose that gets approved. And like Brad said, it's a maximum tolerated dose, meaning, well, we think we can accept X percentage of patients having pretty severe side effects and maybe a few having extremely severe side effects. But what's not discussed but acknowledged within that is that there's a very wide variability of response pretty much to any drug. And some people may live far, far, far longer than the median patient, or have a delay in progression-free survival much longer than the median patient. And then there's others for whom it's much more toxic, and they don't get anywhere near that median. So we, as our own advocates, along with our oncologists, have to be concerned with our personalized doses. Where are we? Where we peers are not uniform. They're have a variety of cell types within the ecosystem of cancer that work together. One quote I always try to keep at top of mind, and I'm sorry, but I can't even say which prostate cancer researcher said this, was that cancer is a meadow and not a cornfield, meaning it's a diverse interacting ecotype and varies for all of us throughout the course of our disease. So all dosing and treatment decisions have to be personalized. And in the end, we are experiments of one. Minimum effective dose is a different concept from maximum tolerated dose. And that's not elucidated in the clinical trials, and it does not correspond to the dose that the FDA finally approves and for whom it approves it, which can be very narrowly defined. The trials are designed to maximize the chance of statistical success for the company who owns the drug, and try to do it with as few people as possible in as short a time frame as possible, so that they can show a statistical effect and get the thing approved. So we need to be wary as individuals that that maximum tolerated dose, the FDA approved dose, may not be the right dose for us individually. So where do we find out the minimum effective dose that's likely to be effective and less toxic? Well, that comes out post-approval in real world studies, when we find that people are not tolerating a drug well, and their oncologists decide to lower their dose. And we've seen this happen. We've seen this happen with enzalutamide. And this has led to the understanding that half-dose enzalutamide, half the approved dose, seems to be very effective, maybe equally effective as the full dose, even though that's not proven. It certainly lowers the adverse side effects. Same for darolutamide. So these are all personal considerations to be taken in and discussed with our oncologists. If we're on a regimen and we find unacceptable toxicity, I would be aggressive, I would say, and even bold about bringing this up to my oncologist. Saying, no, we don't have to stick to the FDA approved. I do not tolerate it. It's toxic for me as an individual, and I would like to try a lower dose because it's been shown effective out in the medical community. Another example would be with abiraterone, which was approved at 1,200 milligrams per day, once a day in the morning on an empty stomach. And then now it turns out, and we know well, that 1/4 of that dose, 250 milligrams taken with a food that includes some modest amount of fat, produces the same effect and levels of abiraterone as the full dose. That certainly saves financial toxicity, even though the blood levels, the actual circulating abiraterone, may be equivalent to the higher dose taken without food. Toxicity for the Taxol chemotherapies. They're very toxic. They're designed to be poisons. Docetaxel, cabazitaxel, paclitaxel. And many people who are advanced in their disease cannot tolerate the full dose, docetaxel, 75 milligrams per square meter body surface area. Well, so many oncologists are using lower dose and changing the frequency of the dose and extending the number of cycles and just modifying the regimen to make it more tolerable. I keep remembering that I don't know of a single patient who was cured of prostate cancer by Taxol chemotherapies. It does not lead to cure. It only leads to suppression of the growth of the disease, which is a good thing, and it can add to survival. But how much toxicity is worth accepting for that? That's an individual decision. Okay, so we have this balance of toxicity versus efficacy. And there you can,
Paul, just a quick interruption, sorry. You're breaking in up a little bit as you talk. I think you have a low bandwidth connection. And maybe if you could turn off your video, more of the audio will come through.
Okay, doing it.
Thanks.
I want to raise also.
And Amit, you have a quick question?
Yeah, I kind of, so Paul, the examples that you're talking about, I think the first example you took, Enza at half the dose as shown to be equally effective. Are these examples, again, coming out of some controlled studies that have been done, or these are just anecdotal evidences? Because I'm actually going through the reduced dosage of cabazitaxel and carboplatin right now for past 3-4 months, and I've been dealing with this dilemma of is it working, not working, and I want to understand in the examples and things that you're talking about. Again, are they? Maybe they are not full trials, but are these controlled studies, or these are just individual?
Thank you for your question, and the answer is no. I said, as I guess I indicated too briefly, this comes from real world clinical practice in the community post approval. And the drug company is not going to go back and do another clinical trial for a different dosage. But sometimes they acknowledge it, that, oh, yes, this seems to be effective because of the weight of experience of oncologists and patients in the community who have tried lower limit dose due to intolerable side effects and found that, wow, it seems like my response based upon my scans and my PSA seems to be just as good. So enough of these reports come in, and then it gets acknowledged and also gets published. So it is in the literature, but they're not randomized controlled trials because that's just not going to happen again. The company has the drug approved. So this has to be gleaned from experience and tested in those who don't tolerate the first dose out of their own choice in consultation with their oncologist.
So somebody is systematically aggregating that data to be able to make that statement, as opposed to, well, in one patient or 5 patients, I found this by one oncologist, right? There's some systematic gathering and aggregation of this data then.
Well, I don't know that there's a formal process to aggregate that. There is a formal process to aggregate information about toxicity on an ongoing basis. But these get published maybe some years after the approval of a drug. And if you can do a search on Medline or even on Google and say a reduced dose enzalutamide efficacy, and perhaps pull up published reports of patient series experiences that support this. But the weight of evidence is slow to accumulate in this manner. I'm just trying to raise the awareness of the possibility of personally trying to find a minimum effective dose, which is a moving target, and you're looking in the dark for it. But that the maximum tolerated dose, it may not be gospel for everybody. It may not be appropriate or even tolerable for everybody.
Thanks.
Another topic I want to raise before my time runs out here is drug-drug interactions that have to be considered anytime we start a new medication. A lot of the drug interactions are due to how the drugs are metabolized. And there's a group of enzymes called cytochrome P450 enzymes, which live on the endoplasmic reticulum inside cells and on the inner mitochondrial membranes. And they metabolize the majority of drugs and other substances and do other metabolic activities. And these have a limited capacity. So if you take a drug that is metabolized by cytochrome 3A4, for example, and then you introduce another drug that's metabolized by the same one, your drug levels may be altered dramatically, depending upon whether the drug induces more of that enzyme, or it inhibits it, degrades it, or is metabolized by it. Hold on, let me finish my train of thought before you ask a question, please. So you can look this up very easily, and we should. I won't go into many examples, but there's our powerful examples within the prostate cancer drugs where they interact, abiraterone and enzalutamide, for example. And this is where the grapefruit juice inhibition of cytochrome 3A4 comes in. So these need to be checked online by doing a drug-drug interaction check on your computer, very quick and easy to do whenever you add a new medication to your regimen. Okay, now your question, please.
I don't know if others have questions, but I just wanted to throw in a couple comments, Paul. Maybe I don't know if anyone is aware, but there's I was watching last night a new Netflix series called Painkillers, and in it the drug it's the story of OxyContin, Purdue Pharma, and the opiate epidemic. And in it, the drug salespeople are being encouraged to they're being paid on commission on the amount of milligrams sold, and so they're asking all the doctors to increase the dosing to prescribe more so they can sell more drug and get reimbursed more. So you would think that maybe this system is designed to serve the pharmaceutical companies a little bit if you're of a suspicious nature. And then I also saw this morning, and I'll put these in the notes, or maybe share it on our discussion forum. But George Lundberg put out a post about a group in Canada that's looking at the right kinds of measures for drugs and measuring overall survival and quality of life to a greater extent than progression-free survival, because progression-free survival, again, encourages more drug consumption. So the pharmaceutical companies are optimizing for that, which may be not taking into account fully quality of life and overall survival as much.
Very good point. Thank you for bringing that up. Yes, and quality of life needs to be front and center, along with duration of life and progression and overall survival. Even though both are very important, and yes, the drug companies, executives have financial motivations that need to be considered. I want to share one other example. This one's more moving into the adoptive therapy realm. A recent study published on adoptive abiraterone. This was by Gatenby, who's adoptive therapy guru, and this is a cohort study. It's not a randomized placebo-controlled clinical trial, but they had patients that were going on to abiraterone for advanced prostate cancer, and they decided to take half of them and do a program where, when their PSA dropped to half of where they started the abiraterone level, PSA drops by 50%, they would stop the abiraterone discontinue it until the PSA returned to that up to that baseline level. And they compared this to a cohort that started abiraterone in similar disease states, but stayed on it continuously. And what they found was very interesting, that those who did the adaptive approach, stopping and starting from 50% drop back up to baseline, had and they were off the abiraterone for almost half the time, about 46%. And the time to progression was 33 and a half months in the adaptive protocol versus 14 months on continuous abiraterone. And overall survival was almost 60 months, 58.5 in the adaptive approach versus 31.3 in the continuous abiraterone, showing clearly a powerful advantage for an adaptive regimen. This was not using some computer algorithm that Gatenby likes to do. This was very simple. Stop it when it hits to 50%, was selected arbitrarily, and restart when you get back to your baseline. And so you're using half the drug, you're off the drug half the time, and you live over twice as long, and over twice as long to progression. So it shows that these continuous drug to failure, which always selects for the resistant strain and the meadow of our prostate cancers, are suboptimal, and continuous maximum tolerated dose to failure always selects for its own failure. And any drug that's started to treat cancer that does not immediately result in cure ultimately leads to its own failure by selection for resistant strains. So that's our catch-22, because these, like combining ADT with a second generation androgen receptor drug, increases survival. We know that, even while it's selecting for its own failure. Why is that? What's the paradox? Paradox is that the combination drugs actually slows down replication. So it slows down accumulation of mutations that lead to the failure. So even though it's making it inevitable, it's giving us survival advantage of some duration. Well, that makes it our position in selecting drug regimens very, very difficult. And I do not have the answer for it. So I'll stop there. If there's any other questions, or move on to the next presenter.
I just have a couple of comments on that we had, of course, Dr. Gatenby on twice. And so if you're interested in exploring those topics further, those are out there and published. Anybody else have any questions before we move on to Jeff Krolick and then Russ?
Yeah, I do this, John. It was a part of Paul's thing was senescence, clearing out the senescent cells. Can you speak on that a little bit?
Yes. Cancer treatment with radiation, chemo, radioligand pharmaceuticals that are toxic, very toxic to cancer cells, good thing, also results in creating a population of cells called senescent cells that no longer reproduce, but they produce cofactors that promote the expansion of the surviving cells and their spread and being able to create metastases. This is called the senescence-associated secretory phenotype, SASP. And these are induced by therapy. So there's treatment emergent senescent cells. And I personally have chosen an unproven regimen that has been proven to clear senescent cells in general. And every 4 months or so, I do a 3-day regimen of substances that are known to clear senescent cells to cause them to do autophagy and die. And I suspect that this is a good thing. And this has not been proven. This is outside of standard of care. But I take a 3-day regimen, which is all that's needed, including 2 natural substances, quercetin and ficitin, 2 phytochemicals, very safe, very well tolerated. You can buy them on Amazon, combined with one medication called dasatinib, which is also a powerful senolytic, a drug that clears senescent cells. And my personal regimen is 100 milligrams of dasatinib daily for 3 days, combined with 1,000 milligrams each of quercetin and fisetin. And is this adequate? Is it helping? I can't prove it, but it's on my side, and I'm acceptable to the toxicity. Dasatinib at that level has very low toxicity, and fisetin and quercetin have zero toxicity. And one could do a regimen without the dasatinib if you wanted to keep it completely natural.
Let's move on to Jeff Krolick. Jeff's he's got his Portland background there, and he's going to tell us about some of the things that he's personalized his dosing working with his medical team.
Good morning, everybody. So I had been working with Moffitt Cancer Center, Bob Gatenby, Joel Brown, primarily with my oncologist, Dr. Lamont. And we had been following an adaptive protocol using Orgovix. And, we were graphing out the PSA results, and I would start and stop based on that. Orgovix, for me, has a very, very quick reduction in testosterone, and there's also a very quick testosterone rebound. And so we were bouncing back and forth between, as low as they wanted it to get based on calculations and as high. And that seemed to range, although this can be unnerving too, somewhere between a low of PSA of about 6 or 7 and a high of up to 30. And this would cycle, we kind of settled into about a 2-week cycle, although it was always based on how quickly the PSA went up in their calculations about that. What changed the approach for me was I've been having some hip pain, which corresponded to a metastatic lesion in my left hip socket, the acetabulum. So we thought SBRT treatment, stereotactic body radiation therapy, would be a good solution. And while we were kind of preparing for that, Gatenby and his team said, why don't you only have 3 metastatic sites, you have very low volume. Why don't we look at an extinction approach and do all 3 sites with SBRT, and then do a second strike, and then we'll look at a third strike after some genetic testing. So that's where I am currently. I'm kind of in the second strike, which is Orgovix and abiraterone, at least for prescribed medication. And that seems to be going fine. So that's, for me, kind of the personalized piece of the usual prostate cancer medications. However, there's some other things that I do for myself, one of which is I take some over-the-counter supplements that provide arabinoxolin, which is a rice bran fermentation. And what I found in actually doing some NK cell, natural killer cell activity tests, and natural killer cell are part of the immune, the innate immune system. and natural killer cells, or a variety of them, can be quite cytotoxic to a variety of viruses and cancers. Cancer cells and their microenvironment are very good at inhibiting many of the signaling pathways that tell natural killer cells and other adaptive immune system components to, hey, don't go here. So Quest Diagnostics, at least on the West Coast, used to have an NK cell activity test available. They don't any longer, although I believe they have this available on the East Coast or maybe the mid-states. You would have to check. But when it was available, I was actually able to test NK cell activity. And in general, my NK cell activity fell below the threshold that Quest Diagnostics determined was basically not active at all. So working with my oncologist, Don Lamont, in a kind of roundabout way, what we found was certain over-the-counter supplements that have arabinoxolin, when taken in combination with valacyclovir, which can inhibit DNA replication in herpes, some evidence that it can do it for Epstein-Barr, both of which have mechanisms to kind of tamp down the immune system by themselves. So what I found is taking 1 gram of valacyclovir daily, and then once a week taking 3 grams, all the while taking the arabinoxolin, actually could increase my NK cell activity from no activity to low normal in the high teens or 20s. And I was able to do this for, I think, 3 months in a row with monthly testing. So it's a leap to say that that translates into some cancer cytotoxicity, but it may very well. So and I don't have any side effects from the valacyclovir, which is an antiviral, and you have to get a prescription for it. But I did find, again, through my evidence of the Quest Diagnostics NK cell activity test, that this actually worked, and it worked quite well.
Jeff?
Yes.
I just want to comment on that. Thank you for that. Since you talked about extinction dynamics, how do you make cancer extinct by using first strike, second strike strategies? And I've done this myself, but I want to point out one difficulty. Personally, I did SBRT to all of my identifiable lymph nodes, the only cancer sites I had, last year. And I followed it 1 month later with radioligand therapy, lutetium J591, monoclonal antibody in Australia. And then, of course, I'm on bat treatment, my own bat treatment. I won't comment on that because we have Russ here now. But I just want to say that Gatenby points out that the second strike optimally needs to be given at exactly the point where you reach no evidence of disease. When the first strike is maximally effective, and say your PSA goes undetectable, that's exactly when you need to apply the next strike. Let's say I recently went to undetectable PSA for the first time. And if I was doing that, I would ask my oncologist for a few rounds of chemo right then, which is really hard to undertake. It's really difficult emotionally to go for an additional toxic treatment at the exact moment when everything seems to be going so well. But that's what the extinction dynamics calls for. And Gatenby points this out, that it's a very much a challenge. And yes, I have not opted to request docetaxel chemo at this particular time because I know I don't tolerate it well at all. But subsequent strikes need to be given right when things seem to be working so well, and that's exactly when most oncologists want to say, "Oh, it's working so well, let's just keep going until it fails," and then you are not doing extinction dynamics at all. You're in the old model. That's all I want to say.
Right. Yeah. Thank you, Paul. This was actually at Bob Gatenby's recommendation that we were doing this. It is different than the published results for this. He will say, "I'm doing this on a very strong hunch. Taxanes are not possible for me because I have some pre-existing neuropathy, and I do not want that to worsen." But anyway, this is again my N of 1 for the extinction piece. And my radiation oncologist was also involved in this discussion. So anyway, this is what we are aiming for if we don't get the results we're hoping. In the third strike, based on when we get some genetic testing back, there's some indications that a PARP inhibitor might be the third strike. So anyway, that's where we are with that. The other thing that I wanted to talk about, because there was some interest before, is not really related to my cancer dynamics per se. It is related in terms of my emotional response to cancer dynamics. But I've been following a psilocybin microdosing protocol for pretty close to a year now. And my subjective experience is it does help. And I also am a meditator, but what I found is with the psilocybin microdosing, that it helps with my mood. It helps with at least my mental energy level. I can't say if it does or doesn't with my physical energy level. And I also, again, subjectively find that my mental focus is better. Through a year and a half of
That's great, Jeff.
deprivation therapy and on and off of Orgovix. I'm
Jeff?
not really experiencing.
Jeff?
Yes, go ahead.
That's wonderful. We only have 7 minutes left. Can we let Russ give us a...
Sure.
Russ had to step away, Paul.
Thank you.
Russ had to step away. He's dealing with an issue, so I don't think he'll come back. So we can let this go and let Jeff keep talking.
So again, my experience is I haven't really experienced mental fog that androgen deprivation therapy can cause or exacerbate. And again, not even so much the physical fatigue. Also, at my age, I'm 71. There's some natural, neurological, cognitive decline, and there's some pretty good evidence that microdosing, in particular for seniors, seems to slow down or even reverse some aspects of cognitive decline. So those are the things that I do. Those of you who are interested, I grow my own psilocybin, so I know its source, and and microdosing is taking maybe a 10th to a 20th of what would be considered a fuller dose. So if anybody is interested in such a thing, Paul Stamets is one of the researchers and developers and promoters of microdosing. If you want to take look up Paul Stamets and the Stamets stack, you'll find information about the research that's been done and the possible benefits. And if people are interested in going farther, there is a place where I get psilocybin spores. And there's another place where I get growth medium. And it's not that complicated to do. So if anybody is interested in more information about that, you can certainly contact me, and I'd be happy to give you, the link to the website for the spore provider, and also for the company that provides growth medium for a variety of different mushrooms. So that's what I have to say about my personalized medicine. Oh, and one other thing, I do take a variety of supplements, many of them mushroom supplements, which seem to have some immune stimulating properties, but I will cycle through all of those. So I won't take any one supplement for longer than maybe a couple of months, and then I'll stop, and then I'll switch to another one.
I should just mention, in case you don't know, that Oregon is unique in being open to psychedelic therapy, and so and Jeff lives in Oregon, so that kind of helps. Amit, you had a question.
More of a comment I wanted to kind of share. But I mean, just to kind of close this, Jeff's last conversation about mushrooms, I've done the same thing based on UCSF integrative oncologist recommendation, cycle through the turkey tail and a Stimets 7 on an every 6-week basis. So that was the recommendation I also got and did that. I'm on, so, different topic. The comment I wanted to make is, I'm on a sort of an adaptive therapy of carboplatin plus cabazitaxel chemo, and the reason for that is limitation of my bone marrow. My bone marrow is highly impacted, and hence my platelet counts and hemoglobin and all of those things are very, very marginal to get the full dosage. So for past almost 4 months, since March 1st, we have been trying just a reduced dose. Every week I get tested, and based on that, my onco and we sit down and make a decision. What's the next dose I can tolerate? Can I get the dual agents or not? Can I, even if I'm getting single agent, like a cabazitaxel full dose is 20 milligram per meter square. And I've been, I've had started with 7, 10, 15, just depending on what it is and how many weeks cadence, everything just is decided on a weekly basis. Hopefully it has kind of kept me stable in this time frame. The difficulty that I see, and I'm kind of curious if anybody has anything to say to that, is my oncos just don't know really, because there's no data to say is this being effective or not effective, because there's no data. So we are doing this because we don't have any other option right now on the table, and this is the best option to deal with my disease. We are continuing to do this and just look at progression, both on scans and PSA. But how effective is it? They just don't know. Many times they have said that we don't know if it's really being effective or not. So that's the difficulty with adaptive therapy and kind of designing dosing. And I got into this situation because there was just no choice. I cannot tolerate full dose, and this is kind of After 5 or 6 consults around the country, everybody was like, yeah, this is what you need to do, and just see what you can tolerate, and not shoot your bone marrow any further. So that's what I wanted to share with kind of my situation and adaptive therapy experience.
Thanks, Amit. It's about time for us to wrap up. Does anybody have any parting comments? Thanks very much to Paul and Jeff for sharing their stories and their perspectives. Anybody else?
Real quick, just getting back to what Paul said about, maximum dose versus anytime when I was on abiraterone, anytime I hit 1,000, my bilirubin would shoot up, and they put me back to 750, and it was fine. 1,000, no way. And both my oncologist and I went for a second opinion, both felt that 750 works just as well, even though the trials are at 1,000. They said, and they don't know, but 500 might work just as well too. But like Amit was saying, nobody knows because the trials just aren't done that way. So,
right.
Well, there in response to that, there's quite a body of evidence accumulated in the community that 250 milligrams in the morning with a fat-containing breakfast works just as well as 1,000 milligrams on an empty stomach. And that's due to absorption issues. One way, if you wanted to test that, would be to take it without ADT and see if abiraterone itself takes your testosterone to a castrate level. Which it is capable of doing in some, but probably not all individuals. But that's been demonstrated by in the community also. And since there's no assay for abiraterone, you can't go measure drug levels that I've seen in community hospitals or even major medical centers. Taking it without ADT would be one way to see how well it works for an individual by its effect on blocking testosterone production in the body.
yeah. Well, I'm off it now, but it was just, like I said, they both felt the lower dose. And they also, I asked about the 250 and they said, with the meal like that, you're going to get blood levels that are going to approach what would be if you took 1,000 with no food, so that they just felt stick to what's keeping my liver happy. But ultimately abiraterone failed for me, so that was it.
Thanks, Bob. Anybody else before we wrap?